Welcome to the Deep Dive. We're here to cut through the noise, find the core facts, and give you those key insights that make you truly well-informed fast. Today, we're diving deep into a really critical area in orthopedic trauma. Hip dislocation and femoral head fractures, our aim. To pull out the essential knowledge, those clinical pearls, and the decision-making points you absolutely need, especially if you're gearing up for postgraduate exams like the FRCS. And for this deep dive, we're using the excellent Ortho Made Simple notes from mokyingren.sg as our guide. These notes were put together by Dr. Mok Ying Ren, a sports surgeon over at National University Hospital in Singapore. He finished his FRCS back in 2022. So we'll start with hip dislocations, then branch into associated injuries like femoral neck fractures, and wrap up with femoral head fractures and how to manage them. Okay, let's get into it. Right, so first things first. High-impact trauma, suspected hip injury. What's the most common direction you're expecting that hip to be dislocated?
Oh, it's almost always posterior. You're looking at about 85% of cases being posterior dislocations.
85%. Wow. And why is that? What's the mechanism usually?
It's often that classic dashboard injury mechanism, an axial load on a hip that's flexed and adducted. That force just tends to push the femoral head straight back out of the socket.
Makes sense. And with that posterior dislocation, what nerves are you most worried about? Any specific parts that are particularly vulnerable?
The big one is the sciatic nerve. Specifically, its peroneal division is notoriously susceptible. We also sometimes see injuries to the lumbosacral plexus roots. There's actually a case report out there about a lumbosacral nerve root avulsion linked to a posterior hip dislocation.
Okay, this is really interesting. Why the peroneal division specifically? Why is it so much more likely to get injured than the tibial division? Is there an anatomical reason?
Yeah, there are basically three key reasons. First, the peroneal division is kind of tethered down in two places, at the fibular neck and back at the sciatic notch. The tibial division, it's really only tethered at the sciatic notch. So that double tethering limits how much the peroneal nerve can stretch or, move out of the way during a dislocation.
Less give.
Exactly.
Yeah.
Second, anatomically, it sits deeper and closer to the hip joint itself.
Yeah.
And third, interestingly, even though it's the smaller nerve overall, it actually has larger nerve fascicles, which might make it more prone to damage from stretching.
So that limited excursion, the proximity, and the fascicle size all stack up against it?
Precisely. It really underlines why you absolutely have to do a careful neuro exam checking peroneal function specifically for every single patient with this injury. It's non-negotiable.
Fascinating how anatomy dictates pathology like that. Okay, so you've identified the dislocation. How do you classify it? Is there a standard system we use?
Yeah, the go-to is the Thomas Epstein classification. It's really helpful for quickly sizing up the injury. Type 1 is simple, no fracture or just a tiny posterior wall chip. Type 2 involves a large posterior wall fracture. Type 3 means that posterior wall fracture is comminuted, like broken into multiple pieces. Type 4 involves an acetabular floor fracture. And Type 5 is when you have the hip dislocation along with a femoral head fracture. It gives us a clear language,
That's a really clear framework. Clinically then, how do you tell a posterior from an anterior dislocation just by looking at the patient and the initial x-ray? What are those classic signs?
Okay, so for posterior, the classic picture is the leg is shortened and internally rotated, maybe adducted too. On the x-ray, because of that internal rotation, the lesser trochanter often looks less prominent or even hidden. The femoral head itself might look a bit smaller, and it's sitting superiorly and posteriorly.
Right, and anterior.
Anterior is just, the leg is often shortened too, but it's externally rotated and abducted. So on the x-ray, that lesser trochanter is usually much more visible.
Got it. So beyond just seeing the dislocation itself, what else are you looking for super carefully on that first x-ray? Any absolute red flags?
The absolute #1 red flag is a concomitant femoral neck fracture, an NOF shag. If you see that or even have a strong suspicion, you absolutely cannot try a closed reduction. It means an urgent CT scan is needed before any manipulation.
That changes everything.
Completely. And besides that, you're also looking carefully for other associated injuries, acetabular fractures, maybe bits of the femoral head broken off. Missing these can really impact the treatment and the outcome.
Okay, so let's say it's a posterior dislocation, no obvious neck fracture on the initial film. What's the immediate plan, step by step?
Right. Immediate plan is straightforward, but urgent. Reduce. Get that hip back in the socket as soon as possible. Then you might consider temporary traction, KIV traction, keep in view, just to maintain the reduction sometimes. And then always get a CT scan afterwards.
You mentioned reduction first. What are the main maneuvers for getting a posterior dislocation back in?
The workhorse is the Alice maneuver. Usually needs 2 people. One stabilizes the pelvis, really holds it down. The other person, often standing up on the gurney, pulls upwards on the femur, usually with the hip and knee flexed, applying a bit of internal and external rotation to kind of wiggle the head back over the rim and into the socket.
Any others worth knowing?
Yeah, there's the Bigelow maneuver, where you use your forearm sort of like a lever under the knee, and the Captain Morgan maneuver, where you use your own knee under the patient's flexed knee as a fulcrum. But Alice is probably the most common starting point.
And for an anterior dislocation, is the reduction technique different?
You could actually use a modified Alice for anterior too. You still apply traction along the axis of the femur, maybe with slight hip flexion, but then you typically internally rotate and adduct the hip, maybe applying a gentle push laterally on the thigh to guide it back in, basically reversing the direction of dislocation.
Okay, reduced. Then the CT scan. What exactly are you looking for on those fine cuts? What details does the CT give you that the X-ray didn't?
The CT is crucial post-reduction. You're looking for a few key things. One is marginal impaction. That's where the articular surface and the bone underneath got crushed during the injury. You're also looking for any remaining fragments floating around, loose bodies in the joint, which can cause problems later. And critically, you get a really good look to rule out any subtle femoral neck fracture that might have been missed on the plain films. It confirms the reduction is concentric and identifies anything that needs fixing.
We keep hearing about urgency. Is there a specific time window for reduction that really matters for outcomes?
Yes, absolutely. Time is tissue, especially here. The traditional goal is reduction within 6 hours of the injury. There was a study, I think JOT 2013, that showed significantly worse results, more complications, less satisfactory outcomes if reduction was delayed beyond 12 hours.
12 hours seems to be a critical cutoff then.
It really seems to be. The risk of complications, especially a vascular necrosis or AVN of the femoral head, just goes up the longer it's out. So rapid reduction is key.
Makes sense. Okay, hip reduced. CT's clear of major issues. How do you definitively manage that straightforward Epstein-Thompson type 1 dislocation? The simple one.
For a simple type 1, it's non-operative management, usually just partial weight bearing for about 6 weeks, gives the capsule time to heal.
And what about an isolated posterior wall fracture? That's
Right.
type 2, right? How do you decide if it's stable enough for non-up or if it needs fixing? That feels like a big decision point.
It is a big decision, and assessing stability is key. There are a couple of ways. One is just looking at the size of the fragment on CT. People use different cutoffs, like if it involves more than 20% or 40% or maybe 50% of the posterior wall width.
The sizes and everything.
Not always. A more definitive way, famously advocated by Tornetta, is using dynamic stress views under fluoroscopy. You do this under general anesthesia. You basically flex the hip and apply force, internal, external rotation, extension, abduction in the direction that would cause instability, essentially trying to subluxate it. Tornetta described using sufficient force to rock the patient on the table. You watch under fluoro to see if the head stays congruent in the socket.
Wow, really stressing it.
Exactly. It highlights that static images might look stable, but the hip could be unstable dynamically. That dynamic assessment is often crucial to decide if surgery is needed.
Looking ahead then, what are the main long-term complications you worry about after any hip dislocation?
The two big ones are of vascular necrosis, AVN, of the femoral head where the blood supply gets disrupted and the bone dies. And the other is heterotopic ossification, or HO, which is where extra bone forms in the soft tissues around the hip. Both can cause significant long-term pain and dysfunction.
Okay, really important points. And just a quick reminder for everyone listening, this deep dive is drawing heavily from the Ortho Made Simple notes. They're a fantastic, streamlined resource you can find over at mokyingren.sg. Really helpful stuff for residents. Right. Let's tackle that really tricky situation. Hip dislocation with a femoral neck fracture, the NOF SHAR. You mentioned it's a red flag. Why is avoiding closed reduction so critical here, and what's the immediate step?
Okay, this is absolutely critical. If you see or even strongly suspect a femoral neck fracture along with the dislocation, do not attempt closed reduction. Full stop. You must get a CT scan first. Why? Because trying to reduce it closed can easily displace that neck fracture further, or even complete it if it wasn't fully displaced. That drastically increases the risk of AVN.
And I guess it's hard to manipulate the head if the neck is broken.
Exactly. You lose control. You can't effectively maneuver the femoral head back into the socket. It's just dangerous and ineffective. Trying it blindly risks making things much, much worse for the patient's hip long term. And getting a CT first, I mean, in my place, we can usually get one within an hour. There's no excuse not to.
So CT confirms the NOF SHAG. How do you proceed then? Does it matter if the neck fracture is displaced or not?
Yes, it definitely matters. The algorithm changes based on displacement. If the femoral neck fracture is non-displaced, the strategy is generally to fix the neck fracture first, very carefully, and then gently reduce the dislocation, often openly.
Okay, fix first, then reduce.
Right. But if the femoral neck fracture is displaced, you flip the priority. You need to perform an open reduction of the femoral head into the acetabulum first, get it back where it belongs, and then fix the femoral neck fracture. The idea is to restore anatomy and minimize further vascular damage.
That makes sense. Handle the displacement first. Okay, let's shift gears slightly to femoral head fractures themselves, maybe without a dislocation initially or found after reduction. Are these common on their own?
It's actually pretty rare to see a truly isolated femoral head fracture. They're much more commonly associated with a posterior hip dislocation, and often you'll find an associated posterior wall fracture of the acetabulum too. They tend to happen together as part of that posterior impact injury.
So how do we classify these femoral head fractures?
We use the Pipkin classification for these. It's based on the location of the fracture relative to the fovea, which is that little depression where a ligament attaches. Pipkin type 1 is a fracture below the fovea, so not on the main weight-bearing part of the head. Type 2 is a fracture above the fovea, crucially involving the weight-bearing surface. Type 3 is any femoral head fracture combined with a femoral neck fracture, that scenario we just discussed. And type 4 is any head fracture combined with an acetabular fracture. It's a practical system that guides treatment.
Okay, based on those Pipkin types, what's the management strategy? Is it usually surgery?
Yeah, management often boils down to excise, fix, or replace. For type 1, the fragment is small and non-weight bearing. There's debate, but excision, just removing the fragment, often seems to give better results than just leaving it or trying non-op.
And type 2, the one on the weight-bearing surface?
Type 2 generally needs fixing. Because it's on the weight-bearing dome, you want anatomical reduction. So open reduction and internal fixation, usually with small headless screws, is the standard. Unless maybe it's an elderly patient with poor bone quality or the fracture is very comminuted. In those cases, you might consider a replacement instead, like a hemiarthroplasty or even a total hip replacement.
Right. When you do need to operate to fix a type 2, for instance, what surgical approaches are used, and are there concerns about blood supply with these approaches?
There are a few main options. You could use an anterior approach, like the Smith-Peterson, although some surgeons worry this might risk the remaining anterior blood supply to the head. A posterior approach, the Kocar-Langenbeck, is very useful, especially if you also need to fix an associated posterior wall fracture. And then there's the trochanteric flip osteotomy, which gives great exposure while aiming to protect the blood supply.
Which one is preferred?
Well, the notes suggest a combination can be very effective. Using the posterior Kocar-Langenbeck approach, especially if you need to fix the acetabulum, but combining it with that trochanteric flip osteotomy. This lets you dislocate the hip anteriorly, gives you excellent visualization of the head fracture, preserves the posterior blood supply, and still allows you to address the acetabulum through the same posterior incision. It's quite elegant.
Tell me more about that trochanteric flip osteotomy. What's the key benefit? How does it protect the blood supply?
The major advantage is that it's specifically designed to preserve the deep branch of the medial circumflex femoral artery, or MCFA, which is the main blood supply to the femoral head. The technique involves cutting the greater trochanter and flipping it anteriorly with the attached muscles. This allows the hip joint to be dislocated anteriorly. You incise the anteroinferior capsule. Crucially, you make sure not to cut or excise the obturator externus tendon because the MCFA runs very close to it or within it. Preserving that tendon helps protect the artery. It's a smart way to get access while respecting the vascular anatomy.
Very clever. Does using one approach versus another, say the trochanteric flip versus an anterior approach, lead to different rates of AVN down the line?
That's a really important question. Interestingly, a study by Giannoutis and colleagues back in 2019 looked at this and found no significant difference in AVN rates between the trochanteric flip and anterior approaches.
Oh, that's reassuring.
It is. It suggests that perhaps the surgical technique and handling of the tissues might be more critical than the specific approach itself, assuming it's done well. It gives surgeons some flexibility based on the fracture pattern and associated injuries.
Okay, last question on this topic. What are the main complications we should specifically associate with femoral head fractures or their surgery, besides the AVN we've already covered?
Well, heterotopic ossification, that extra bone formation, is definitely a concern, maybe slightly higher risk with the anterior approach. That's why prophylaxis, often with indomethacin 75 milligrams daily for 6 weeks, is commonly recommended after these surgeries. And then, of course, you have the general risks of any major hip surgery.
Right. So we've covered a lot of ground here, from recognizing the common posterior dislocation and its nerve risks, to classifying these injuries with Epstein and Pipkin, the absolute urgency of reduction, especially before that 12-hour mark, the critical need for CT scanning, especially if you suspect a neck fracture, the different management algorithms for simple dislocations versus those with wall or neck fractures, and the nuances of surgical approaches for femoral head fixation, like that trochanteric flip. So, what does this all mean for you listening? It means having this structured understanding, the why behind the classifications, the maneuvers, the approaches, is going to be incredibly valuable. Not just for passing your exams, but for making sound clinical judgments when you face these complex injuries in practice. And to leave you with something to think about. Considering all the potential associated injuries and subtle signs we've discussed today, what single clinical finding or radiographic sign do you think is most often overlooked in complex hip trauma that could actually change the entire management plan? Something to mull over. Thanks for joining us for this deep dive. And remember, this session was built on the foundation of the OrthoMade Simple Notes you can find on mokyingren.sg, a great resource designed to help you get straight to the crucial information.